I'm going to talk today about social influence factors and how they might be used to promote change among older adults. And I'm going to focus specifically, as some of the friends in the audience may have heard this before, on group-mediated cognitive behavioral interventions, an intervention that I developed with Jack Rajewski at Wake Forest University. But I'd just like to acknowledge my PhD students and also my postdoc who helped put together some of this work. So let's begin. I'd like to talk about social influence in these interventions and particularly look at it from this particular type of agenda. First of all, does it matter in affecting lifestyle change for older adults? And if you listen to the first presentation, certainly it seems to matter. Secondly, I'd like to talk about the tactical use of the group as an agent of change. Third, is this particular intervention efficacious? And then finally, does this intervention model hold opportunities for older adults to thrive? And I'd like you to dwell on the word thriving in making physical activity changes. So let's start. So first of all, I'd like to look at social influence from two perspectives, social isolation and social support. And we know that when older adults are socially isolated, we have all kinds of problems: depression, poor health status, and that's often concurrent with chronic disease and disability. So the absence of social influence seems to be correlated with these kinds of problems. But if we look at social support, it tends to have a buffering effect on depression and anxiety that we see across all age groups. But most recently, Feeney and Collins have written a paper that said, let's take a look at something other than the buffering hypothesis, and let's look at this from a different perspective. And that perspective is thriving. And what we mean by that, or they mean by that rather, is that you can thrive through successful coping with adversity, like a chronic disease, or you can thrive through the active pursuit of growth and development in the absence of adversity. And they describe thriving as having 5 components. I'm not going to belabor them here, but it's interesting to me to note that one of the last ones they focused on as social psychologists is physical well-being. And so what do they mean by physical well-being? Well, if you look at those characteristics, those are all the things where we want older adults to thrive. We want them to live longer. We want them to have elevated health status and so on while they're doing that. And we want it to be in the absence or in the control of chronic diseases. All right. One other thing that I think is particularly interesting when you have people integrate a lot of disciplines. If anybody has ever read any of the work on Bessel van der Kolk, he's somebody that deals with trauma. And he tends to integrate everything from neuroplasticity to biology to social science. And his point here is that social connection is a biological necessity. His view is that this should be the backbone of all prevention and treatment. All right, so what source of social influence can we use to help older adults and facilitate lifestyle change? I think there's a lot of social science evidence, particularly from group dynamics, that emphasizes the power of groups to motivate change. But I want to clarify that in a moment. There's also the practical reality of delivering interventions and being feasible. We do a lot of stuff in groups, like train, educate, and intervene with groups, so why not use them as an agent of change and better effectiveness? But there is a difference between just delivering some of that education or intervention to a passive group of people who are just a collection of individuals versus a group that's consciously formed with the idea of motivating those people in that particular group. And these are active participants who collaborate with whoever's working with them to try to enhance their experience and enhance their thriving. Well, one of the things that Jack and I argue is, can we use the older adult groups to effectively provide some of these things that we've been talking about so far, not only social connection and social support, but enhanced learning and practice of change, and hopefully it's self-management and maintenance. And so I'm going to say yes, we are. And of course, that's my intro into the group-mediated cognitive behavioral intervention, or GMCB, as most of us have already had lunch and don't need that big a mouthful. All right, so what about the role of the group? How does this group happen? And what are some of the things that make it powerful? I'm just going to touch on a few things. This literature's been around for a long time. In fact, in the 1950s, it was often used with army groups and so forth to motivate different kinds of forces. Cartwright is famous for this, as well as the sheriffs as examples. But why they're effective is that groups encourage a lot of commonality to get people to act and think in the same way. So they have common attitudes and goals, i.e. the need to change one's lifestyle, and also the behaviors that go along with those, particularly the kinds of behaviors we need to get people to maintain or be persistent at something. And so lastly, the interesting catch with groups is they actually get people to do stuff when they're away from the group, as long as that behavior is something that matters to the group. All right. Now, the group as agent of change principle sort of focuses on one common thing that I think we'll find advantageous, and that is the need for change, or what we call a motivational base. That's why the group was formed in the first place, and so here are a number of examples of motivational bases, why people get involved in certain kinds of groups. But they're there to get trained. Can we use that in a way that enhances all of those motivational bases, remembering that if we do that, those common attitudes, beliefs, and behaviors may foster a better type of change. The other thing that you have to look at is that the people in group psychotherapy and counseling have been doing this for a long time and recognizing the power of the group and the effectiveness of having people participate with one another. And so they've talked about the different types of processes that make things happen in a group and increased involvement of all group members. And I stress again, not passive. The therapist-patient collaboration increases, and if you've read anything about trying to motivate individuals, that kind of collaboration is at the center of patient-centered care and also a goal for self-management. There's the acceptance of common goals for both rehabilitation and self-regulation in relation to whatever the psychotherapy or counseling group is doing. And then finally, when you talk with one another and say what your problems are and so forth, you're actually making a public commitment that tends to promote adherence. And if you think about Weight Watchers, whatever you think about Weight Watchers or Alcoholics Anonymous, people get up and say, yeah, I'm an alcoholic. I'm not really. But in that particular case, you have a public commitment that tends to keep people on that same rail riding forward. All right. But the group alone won't do it. There are other processes well known that also contribute to behavior change, and these are some of the self-regulatory strategies we use. And in this case, the toolkit is a metaphor for some of these strategies. So let's take a look at something I presented when I gave the Lindvandian lecture a couple of years ago, and I presented this position statement. And this was not a psychologist's conclusion, but the American Heart Association's that said cognitive behavioral strategies are an essential component of behavior change interventions because they get people to self-reflect, they get people to focus on what they're doing in their behaviors, about their surroundings, and how to change their lifestyle. We followed up on that particular paper by reviewing reviews that were in addition to this, and the conclusion was the same. The effects of employing these strategies that is at least a moderate level good enough for clinical practice. So now, what are those skills? And I'm not going to spend much time explaining any of these because many of you will have seen these before. In fact, behavior change skills, all of those are characteristic of learning, of coaching, of teaching. But the self-regulatory skills try to get people to adapt and problem solve, as you can see there, and in addition, cope with any lapses they might have. So how do we get those into an intervention? Well, what we do, and I have to abbreviate this, obviously, I can answer it in more detail, but the stepwise fashion is the way that we teach these in an intervention that has an exercise component. It already has the training and everything in the intervention. Somebody else has established that. Or if you think of the model of cardiac rehab, standard cardiac rehab is the way people get their exercise. But in these skills, they're essentially taught once a week for about 25 to 30 minutes, and we progressively teach them over the course of, for example, cardiac rehab, to the point where they're also doing these in conjunction with their fellow group members and interchanging on how successful they are, any problems they have, and essentially doing homework as they work forward each week, to the point where they eventually get to this toolkit that is used as an adaptive process for self-maintaining once they leave the cardiac rehab situation. But I want to stress once again, the group is the foundation, so we're sharing, we're all in the same boat, and we're sharing how we're doing with this progress. All right, now to try to illustrate how the group might foster another kind of thing that I think everybody in this room has heard the term self-efficacy as a powerful kind of belief that tends to motivate people's behavior. But the group can contribute to that, and I'll very quickly outline that. So how does group process contribute to self-efficacy? Well, self-efficacy comes from a variety of different sources of information, like any other kind of belief. One is direct experience. Are you successful or not successful at doing something? Successful or not successful at the exercise you're being given or the learning of these different kinds of skills. The second type of thing is more of an indirect effect of being in the group. You watch other people and you have observational learning. You model what's going on with other people. Both of those are sources of efficacy. So the first one, we plan the direct experience. The other, vicarious and observational learning, comes about through exposure of being in the group. We also plan supportive feedback and interaction, which is verbal persuasion. No news to anybody, that's another big source of efficacy. And then finally, just being in the group and developing this cohesion and safety net of being there, everybody else is like me, they're going through similar problems, also adds to another source of efficacy. So the group seems to be very powerful in contributing to motivation and also developing some of these other forces that we deem important in motivating people. So bottom line, we have people practice their self-regulatory skills as they go through the intervention, and they get feedback from a variety of sources, trying skills on their own, obviously from the interventionist, and then finally from all the other members of the group every week. Now to give you an idea just to what kind of an intervention am I talking about, here's a little model. We have the intensive phase of an intervention going for about 3 months, and then in many different trials you have a maintenance phase that goes for varying lengths of time. And what we tend to do is compare a treatment group to a control group. And the treatment group in this case, if I could add group in there, the groupie aspect of it that I've described would be the GMCB condition. One thing we also do is plan a transition phase, so people are actually taking and planning their own programs about what they're going to do once they leave the setting, whatever the setting might be, rehabilitation or otherwise. So they still have practice while they're actually in the intervention and get feedback on how well their own self-regulated programs are doing. They're not being told to do that by others. So that's the model, the intervention framework. So basically, the whole intervention is combined ingredients. If you can think of a mixing bowl, basically the self-regulation and counseling tools and the group process go into that bowl. So now the question is, after all that description, are these things effective in any way, shape, or form? Well, they're based on group dynamics theory and on social cognitive theory. So the question is, are we seeing any effects on any of those kinds of variables, and what's the evidence for older adults? So what I'm going to show you is a number of trials that we've been conducting between 2000 and the present day. They've got all those fancy names. Every trial, of course, has to have a sexy name to it in one way or another. I guess if you look at it, depends on how sexy you think those are, but it's just a recognition thing so you can see an audiovisual Hall of Shame slide later on and recognize it. And that is the red brackets are around the cardiovascular type trials. The blue brackets are around the arthritis trials, and then we have one with healthy but sedentary older adults at the top, our very first one. And at the bottom, we have one conducted by Brian Vogt on cancer. So let's take a look at 3 types of evidence of maintenance. And the thing I'd like to emphasize here is on trials, we usually look at what the difference is at the end of the maintenance period. You expect there to be some kinds of differences at the end of the intensive phase. But what happens at the end of the maintenance period? If you read any of the literature, we do a great job in the intensive phase, and then once people get into maintenance, there's this decline. People don't hang on to the change as well as we'd like. So that's what we'll be looking at for each of these three types of outcomes. All right, now here's the Audiovisual Hall of Shame slide, but I'm going to try to group it for you using the past. So this is a forest plot slide. We used comprehensive meta-analysis to look at all the effects in each of these trials. So the effects that are shown here are weighted by sample size. The first group are those cardiovascular trials. And what we have in here is, on this first block, are essentially physical activity effects. The second block really have to do more with physical function, or what we've loosely grouped as physical function effects. Then there's this isolated one on healthy older adults. I think, unfortunately, with the granting agencies, you get more funding for dealing with chronic disease than healthy older adults. And then the arthritis trials, and finally the cancer trials. And what you notice about all of these, if you look over to the far right-hand side of the slide in the yellow shaded area, is that almost all the effects are in favor of the GMCB on the positive side of the ledger. And if you look at the bottom yellow shade, you can see the average effect size across all those effects that are being calculated, which is in the moderate range, which are pretty good for the number of effects in people that are examined. Well, that's physical activity adherence and function outcomes. What about when we look at social cognitive outcomes? Once again, reminding you that cardiovascular group of studies, the individual one on healthy older adults, and then arthritis and cancer. And the cancer studies in this particular case, so it's really a feasibility study, so a very small kind of trial, as is the maintain trial, which I can explain later. But again, looking on the right-hand side of the ledger, you see the effects are all in the positive direction across the board, except for a few non-significant ones. Almost all of those effects are significant, and the average effect size is reported on the bottom. So, what does that mean overall when we look at all those trials and the effects observed? I think we can say that intervening to improve self-managed physical activity via the group-mediated cognitive behavioral intervention does a number of things. It promotes better adherence compared to a control group. The retention of improvements in function are evident. The maintenance of increases in self-efficacy and other positive psychological outcomes are also evident. And then finally, it seems as though older adults, at least from this data, appear to sustain their thriving after participating in that intervention. So, now what about some knowledge translation points? And these are very simple. I, again, can speak to them in other facets. So one of the things you might notice is that we had a number of different settings and diseases that we examined. This enlarges on it because we've done other work with other populations, multiple sclerosis, postnatal mothers, and spinal cord injury. The GMCB strengths, the question to be asked is, can you tailor this thing? And one of the things we seem to be able to do is test it and use it with many asymptomatic and symptomatic populations. Also, Jack Rajewski has managed to take this into the YMCA environment, and that seems to be operating successfully using YMCA lay leaders to be able to deliver the GMCB, or cognitive behavioral component of the intervention. We haven't tried it with different cultural groups yet, so that's still another challenge that awaits. Is it flexible? Well, I think so, because we deal with weight loss, mobility disability through multiple sclerosis, and also some of the other functions that older adults that are obese and frail have to face, cardiovascular, but I still think we need to expand upon that to make sure there's more generality. One of the things about the GMCB is it isn't too hard to sustain at least the training for those people that deliver it in the community or in the environment. there's an initial investment of training, but once it's there, for example, in a community program, it'll sustain itself if these kinds of programs are delivered in the future. And certainly, Jack has had health educators continue to deliver that, and we have certainly had that in different groups up north. The other thing is that there's relatively low cost and time demand to do this in the program itself. It is, for any program that goes on per week over the time period that I had, and again I'll use cardiac rehab as a model, if you go over about 3 months, you're really asking older adults, in addition to their exercise, to put in 25 to 30 minutes per week. There's no real special equipment involved because that's all associated with standard care in the program. Oh, I'm getting the turn down sign. So I'll quickly finish and just say that another thing we need to look at in terms of translation is how much does it take to train? What's the level of education we need for people to go and deliver these interventions? And I would say that pretty much in all cases, the education level is about moderate. We've had postnatal exercise leaders do it that don't have a lot of special training other than the focus on exercise, extension health educators, and YMCA leaders. And we hope to improve upon that in the future. So I'll just get out and get that unhappy face off the desk. Thanks very much, and I'd like to acknowledge our funding agencies. Thank you.